Hey, this is Dr. Livingston, and here is our lecture on disruptive impulse control and conduct disorders. So there are quite a few disorders in this category. Just like before, we're not really going to go over pyromania, kleptomania, and then the other specified and then unspecified. What we're going to really focus on is oppositional defiant disorder, intermittent explosive disorder, and conduct disorder. Now, as a review, these disorders are in this diagnostic category because of how their symptoms are manifested. They are behaviorally based, they violate the rights of others, um, or they might bring the person struggling with these disorders into some significant difficulties with societal norms or authority figures. Antisocial personality disorder could also be put into this category, but it is still felt to be more appropriately placed in or within personality disorders. So first, let's go over a brief diagnostic review. Now, for oppositional defiant disorder, symptoms have to be present for at least 6 months, um, with at least 4 of those symptoms in these 3 categories listed here. Now, we're going to go over the specific symptoms associated with these categories when we go over clinical presentation. One thing to remember is that they have to occur with at least one individual that's not a sibling, because we all know how siblings can fight and argue and sometimes not get along at all. The severity of ODD is going to be based on how many settings symptoms are present. But it is pretty common to see just about all of the symptoms in only one setting. Usually that's going to be with family or family members, or possibly even only at home. What that means is that there might be quite a few people who are involved with the child or teen that really struggle to understand or believe even that a child might have this disorder because they've never actually uh, seen those symptoms or those behaviors. Now, of course, when we're considering this diagnosis, we do have to take into consideration persistence and frequency, uh, because that's going to vary based on age. So below age 5, it's got to be most days for 6 months. Over age 5, we're going to see at least symptoms at least 1 day a week. For intermittent explosive disorder, what we want to keep in mind here is that these are recurrent impulsive outbursts. These outbursts are going to be completely out of proportion to the identified trigger or to the perceived trigger even. And the symptoms associated with intermittent explosive pretty much they represent a failure of emotional control, and that primary emotion being anger with aggressive impulses of acting that emotion out. And for children, anywhere between age 6 and 18, we want to make sure that we've ruled out adjustment disorder first, because we can see aggression with adjustment disorder. And so if that's happening, then this is not going to be an appropriate diagnosis. Now, if you pay attention to these diagnostic criteria here, in general, we're going to see more often verbal aggression, possibly physical aggression towards property, about twice weekly for 3 months. Now, when we talk about this physical aggression, this is not going to result in any kind of damage, destruction, or injury, whether to self or others. On the flip side of that, we may or may not also see at least three behavioral outbursts that do result in injury or destruction. And that is going to occur within a 12-month period. So we're going to have on average these, about twice a week, we see these types of outbursts, but they're problematic, but they're not resulting in any significant harm. Um, but then we might also see in between that much more severe outbursts. And then finally, for conduct disorder, and we're going to spend a lot of time on this a little bit later in this lecture because there's a lot that goes into conduct disorder diagnosis. But in general, we're going to need to have at least three of the diagnostic criteria that are, and there's 15 of them, and we're going to go over those. So we've got 15 criteria that are grouped into these four categories. So we've got aggression to people or animals, destruction of property, deceitfulness or theft, and then serious violations of rules. Now, those three symptoms or more must have occurred within the past 12 months, and at least one of those within the past 6 months. So this is going to be probably one of the only diagnoses that within this category that we can look back 6 months ago, and if something happened, then we're still going to be able to meet criteria. In general, with conduct disorder, the basic rights of others are going to be violated. If we don't quite get to that level of severity, then we're also going to see age-appropriate societal norms or rules that are acceptable for the age that are going to be violated. We also have a lot of specifiers that we're going to go through. So just remember that we have childhood onset, adolescent onset, and then unspecified. We've got the specifier of with limited prosocial emotions, and then a mild, moderate, and severe categorization. When we're talking about the age of onset, remember 10 years old. That's the key. That's our key age. So childhood onset, it's going to be at least one symptom present prior to age 10. Adolescent onset, no symptoms prior to age 10, but they're there prior to age 18. There's not really a diagnostic code or criteria for any onset after age 18, but that's really rare and not typical for that to be the primary presentation. If we have that unspecified, that just means that we don't know exactly when symptoms started. And then we're going to go into what the other specifiers are defined by. Now let's talk about some diagnostic and assessment tools. So one of the issues that we have with these behavioral disorders is that there's not a whole lot of definitive diagnostics when it comes to these assessment tools. And this is because there's such a wide range of behaviors that can be associated with a particular age and experience. And a lot of behaviors that happen within childhood and adolescence can be very transient. It can be because of a group of friends that they're hanging out with. It can be because of a particular situation that's going on, which could categorize somebody as adjustment disorder. But they might not last for the length of time that is needed for these diagnoses to be made. So if we're having some difficulty, we do have these. Now the Conners parent rating scale, the child behavioral checklist, and the schedule of affective disorders and schizophrenia for school-age children present and lifetime. Those are the three that are most commonly utilized. Some of the other ones can also be very beneficial. I personally prefer the Connors scale just in general. We can actually use Connors scale for quite a few childhood disorders. Um, and it's a good one to be familiar with. So let's talk about those clinical presentations. Now, these are all general features that all of these disorders share. Some are more applicable to one and not the others. So let's kind of understand this as a generalization. Um, so, for starters, all of these disorders are based on emotional dysregulation issues. Typically, we're dealing with anger as the emotion, and that anger can lead to aggression and some of these other behaviors that we see. We do tend to see these disorders more commonly in males, but that can vary with age. So that's not really something to lean on. Onset is generally going to be in childhood and adolescence. It is very rare for these to have an onset of adulthood, with the exception of intermittent explosive disorder, but usually we can trace that back a little further. Another thing that we have to consider with these that kind of goes across the board is that we have two primary types of emotional um, responses associated with personality. So we've got internalizing and externalizing. So all of these are going to be an externalizing or on the externalizing spectrum. What that means is that we see more disinhibition, constraint, and emotional or negative emotionality. Um, what that means is basically children and adults that meet criteria for these disorders or had at one time uh, would essentially act out the emotions that they were experiencing. We do have a lot of comorbidities. Substance use disorder or disorders kind of remains a very primary one throughout all of these. Um, and that could be related to attempts at self-medication, or sometimes even these disorders might be as a result of long-term substance use. What we want to rule out is that these behaviors and symptoms are not occurring uh, because of intoxication with a substance or because of withdrawal from a substance. And that's kind of an important factor to consider. So first, let's talk about oppositional defiant disorder. And this disorder is a patient child with oppositional defiant disorder, or ODD, is going to have some pretty characteristic features. Um, they're just going to be extremely resistant to following any direction. They don't like being told what to do. They they like to be in control of every situation. And so whenever an authority figure is telling them not or to do something, we usually see some sort of behavioral response. And that tends to be within a very identifiable pattern of behaviors. Like, we know what this kid is going to do in this situation. Um, we tend to see a lot of hostility, argumentative behaviors, antagonizing, uh, resistance to accepting personal responsibility for consequences of their actions. Um, and then they also tend to frequently blame others for their mistakes. This is one of the leading causes for referrals for mental health services and special education services within our educational settings. Um, Usually, we're going to see onset of symptoms right around 6 years old, but parents and other caregivers can generally identify that symptoms might have started much earlier than that. Now, keep in mind that after early adolescence, it would be very rare for oppositional defiant disorder to appear. And when we see behavioral problems with children, and this kind of goes, across the board with any uh, diagnosis that we might deal with, um, behavioral disorders or even just problematic behavior can be almost predictively traced back to parenting styles. Um, a lot of kids with oppositional defiant disorder tend to have parents that or caregivers that are hostile and overly controlling. And so we really want to evaluate that. When we get into treatment, the disorders that we're looking at in this lecture, there's no medications that are going to quote fix these kids, teens and adults. It is a lot of therapy, and it is a lot of recognition of how a parent or caregiver interacts with these children that might actually be causing or perpetuating or intensifying even the behavioral reactions and outbursts that kids have. With oppositional defiant disorder, we don't really see proactive aggression. We can, but because of just some vindictiveness. But generally speaking, it's going to be very reactive if we see any physical or verbal aggression with oppositional defiant disorder. We will also see a generalized low frustration tolerance and emotional reactivity, not just with anger, but with any emotion that's experienced. And kids with oppositional defiant disorder, they are at a higher risk for conduct disorder development, but that doesn't necessarily mean that that is going to be the progression. We can step in at any point and change that trajectory, but they are at a higher risk if there's no interventions. Again, this disorder is going to be primarily related to parenting and other immediate environmental features and experiences. Usually that's going to be in early childhood or earlier childhood. But if those environments and parenting styles change, then we can certainly see this present in response to that. Now, one thing on that previous slide, of course, we said we have to be at least 6 years old, and so that also means that we have to consider developmental age. We also have to look at the frequency and intensity of the behavior. Is it outside of normal range for age, culture, and gender? Now, with gender, that's kind of a gray area, and that's some very old wording in our text, but still something to think about, just simply because we do tend to see it being more acceptable for males to have these types of behaviors as opposed to females. We also have to think about during adolescence, it is very normal for teenagers to question, defy, argue, and resist authority. And this is a very normal developmental stage of kids during those teenage years. And this is to develop their own sense of self, their own identity, and to kind of stand their ground on developing their own independence to make their own decisions. So now let's look at the specific symptoms that fall under those categories. We've got angry or irritable mood, angry or irritable mood. So that means we're going to see a lot of temper tantrums. If not temper tantrums, then we're just losing temper. Very easily annoyed, and frequently just irritable and angry. Um, and that's going to be more often than not. We see that irritability. When we're talking about argumentative and defiant behavior, arguing with authority figures. Now, keep in mind that with certain age groups, an authority figure can be any adult, any adult. So it doesn't necessarily mean what we might identify as an authority figure. They will actively defy or refuse to comply with requests from those authority figures or just generally with rules. Um, they will deliberately annoy others, but then not be able to um, tolerate another person intentionally annoying them. Like I said before, they're going to very often blame others for their mistakes or behaviors. That reluctance or resistance or even refusal to accept personal responsibility. Then we can see that vindictiveness, spiteful or vindictive behavior at least twice in the last 6 months. Now that's one that has a lot of specificity to it when we're looking at vindictiveness as a manifesting symptom here. Kind of already talked about the persistence and frequency as related to age. So let's talk a little bit about the level of severity. So when we're looking at these symptoms for oppositional defiant disorder, if we are considering it as a mild presentation, then that means that we are only seeing symptoms in one setting. If it's moderate, we've got symptoms in at least 2 settings, and then if it's severe, we've got symptoms pretty much in every setting that we could imagine. I like to, I don't like to, but I tend to describe these children as when they come into your office, um, if you say, I'd like for you to sit in this particular chair, they're going to sit in another chair simply because you asked them to. Um, this might be the teenager that even if they are walking to their room, because that's where they want to be, and a authority figure tells them, go to your room, immediately they no longer want to be in their room. And it's almost like some knee-jerk reactions of, you told me to do something, I am absolutely not going to do it. And a lot of times they will do the exact opposite of what you tell them to do. Another presentation of this might be just more of a shutdown. Tell them to do something and they become a rock in front of you. They're just not going to move. They're not going to do anything that they're told to do. And maybe even when they get their way, they still might continue to refuse to move or comply with any requests. They're very, I'll say, difficult to interact with as an adult, or even with with their peers. They tend to not get invited places because of their behavior. They tend to become more isolated from peers because they're getting in trouble frequently, things like that. So we do kind of have a wide range of consequences that can occur because of oppositional defiant disorder. Now moving on to intermittent explosive disorder. Um, some things that I want to start with first is we are not going to give this disorder to anyone, or this diagnosis rather, to anyone younger than 6 years old. Not going to do it. We're also not going to give this disorder if a child has disinhibited mood dysregulation disorder, or if these behaviors occur during the course of an adjustment disorder. We want to understand that the outbursts that are associated with intermittent explosive disorder are not premeditated, and they are not used in some sort of way to assert power or to gain some sort of reward in their minds. Now, most of the time with intermittent explosive disorder, people who are struggling with this disorder are actually going to be quite distressed by these outbursts because they just feel like they just can't control it. They don't know why they get so mad. They don't know why they behave this way. We might see a lot of remorseful behaviors after these outbursts. Problematic, or I guess the more significant problematic consequences can be that they're going to these explosions are going to impact education, work, social interactions. They might actually even end up with legal and financial consequences because of their actions, we'll say. Now, we can have intermittent explosive disorder co-occur with ADHD, conduct disorder, and ODD, or even autism spectrum disorder. But usually, we are going to recognize the symptoms of intermittent explosive disorder as being or as exceeding those emotional outbursts that can occur with those other disorders that I just listed. So, with intermittent explosive, as this slide says, primary feature is just a lack of self-control regarding those anger outbursts. This is in response to a very minor trigger or interaction. And sometimes even, the person that experiences it cannot identify exactly what it was that made them mad. They are very impulsive and anger-based. They come on extremely quickly. Sometimes can't even see it coming. Usually they're only going to last for about 30 minutes. And for the most part, we're only going to see these in response to interactions and situations that involve people that are close to them. And that has a whole other psychological side of it that we're not really going to get into. But if you look at some of the, well, no, we won't get into it this semester, but we'll talk about it next semester. So anyway, like I was saying before, usually we're going to see a outburst pattern of these less severe, just verbal and non-damaging incidents that are going to be interspersed with more severe destructive and assaultive episodes. Most of the time, in any of these outbursts, any of the harm or destruction is unintentional. So we got to make sure that we keep that in mind, because this is the one out of these three that it really is completely unintentional. Now, sometimes with oppositional defiant disorder, we might see some of that uh, more aggressive behavior and them not realize how severe the consequences may be. But there is more of that spiteful, vindictive, I'll get you back for this type of situation that's going on with ODD as compared to intermittent explosive. Depression, anxiety, substance use, those are highly associated. But again, we're going to see the symptoms of intermittent explosive have an onset that is going to easily be identified as predating depression, anxiety, and substance use. We're not going to see this one so early in life as with oppositional defiant. This is kind of that mid ground of like late childhood into early adolescence. We can also see this onset in adult years too, but that's not real typical. And it's going to be extremely rare after the age of 40. If we see these types of symptoms that have an onset after the age of 40, then we really need to be looking at some other possible causes. Now, once someone does start experiencing these symptoms, those symptoms are going to last for quite some time, sometimes years even. Now moving into conduct disorder. So again, with conduct disorder, this is repetitive, persistent behavior pattern where the basic rights of others are being violated, or those age-appropriate norms and rules are being violated. We got to remember, if the person is over 18 years old, in order for them to have this disorder, they can't then also meet criteria for antisocial personality. It's going to be an either-or situation. There is no guilt and no remorse. Now, if we see guilt and remorse, it is probably to get out of the consequences of their actions. So it's a manipulative expression of remorse. We will more often see proactive aggression rather than the reactive that we see with oppositional defiant. We will also see confrontational aggression. Now, that means that, that's kind of those kids that are, oh, you want to fight? Let's fight. Let's go. Because they tend to interpret the actions of other people as more hostile and threatening than they really are. And so they feel like their aggressive response is justified. It's not that's not a tactic that they're using to say, well, they deserved it. They really do believe that it was justified. So that's something, an assessment, acknowledgement that we got to make. For adolescent females that have conduct disorder, we're going to see more issues with substance misuse than we do in males. We're also going to see that rates of suicide attempts and suicidal ideation are much higher than expected for the age. And a lot of these kids have experienced some significant abuse or neglect history. So they have not come from good homes. They have, they've experienced some pretty significant trauma. And so we have to understand that when we're working with children that meet this criteria. So in general, personality traits listed there are generally negative. We also see thrill-seeking, general recklessness, insensitivity to punishments. They don't care. They just don't care because they're going to do what they want to do anyway, regardless of the punishment. Um, I'm going to post an article that talks about callousness and some physiological traits that are associated with kids that have conduct disorders. So that's very interesting because we do see some identifiable traits there. So first symptoms that we're going to see, and onset is typically going to be somewhere in middle childhood. That can be somewhere in those preteen, late elementary school age range. Rarely are we going to see an onset after 16 years old, and most of the time kids that have this disorder, the symptoms are going to resolve by the time they get to adulthood. We might see some kind of lingering into early adulthood, but generally speaking, we're no longer going to meet criteria for this by the time they become adults. So those first symptoms are usually less severe. You're going to see some lying, maybe some manipulation, shoplifting, stuff like that. And then those are going to progress, sometimes quickly, sometimes a little more slowly, into the more severe. Now, we might not always see those really severe basic human right violations, such as a sexual assault. But we're, if we progress into the more severe symptom presentation, we're going to see more aggression in general. Now, some of the symptoms that might kind of linger into adulthood that may or may not completely resolve are going to be aggression, and that can be verbal or physical, property destruction, deceitfulness, and general rule violations. So these folks are going to have a lot of difficulty just following the rules. Oppositional defiant disorder is a precursor, but not a guarantee that we're going to go that route. And then also there's the association of conduct disorder being a precursor to antisocial personality disorder, but that's not always a guarantee either. When we are looking at prognosis and association with more severe symptoms, adolescent onset, we do tend to see less severity, and especially those kids that do have fewer or more milder symptoms that like just barely meet criteria. Usually, by the time they get to adulthood, they've adjusted just fine and live successful, normal lives. It's with our earlier onset, so the younger onset that we have, the worse prognosis we have, and that places children at a much higher risk for criminal behavior and substance use in adulthood. So let's go over the specifics in those four categories of, or those four diagnostic categories. Now, under that category of aggression to people or animals, bullying, threatening harm to others, in general intimidation of others, starting fights, use of weapons that could cause serious physical harm. Now, sometimes that can be kind of a gray area if that is kind of a hinge point symptom or behavior. But generally speaking, if it could do damage, physical damage to a person or an animal, then it's going to be considered as meeting that symptom criteria. Physical cruelty to people or animals, stealing while confronting a victim. So sometimes with oppositional defiant disorder, we're going to see stealing things that don't necessarily require confrontation. But once we see this level of severity kind of increase into that possible conduct disorder, we're going to see those confrontations. Um, and then, of course, that sexual assault, and that can also be by coercion or intimidation, falls into that category as well. Any level of sexually assaultive behavior. Um, Property destruction. Now, again, when we're looking at a symptom or behavior that results in property destruction, we have to look at, was it intentional? Because with kids with conduct disorder, it is. Um, Deliberately starting fires with the intention to cause damage. Now, if they deliberately started a fire and they didn't really think about it causing damage, um, then they might not meet this symptom criteria. Same thing with destroying others' property. Um, Maybe they did, but maybe they thought that they could put it back together, or that it, wasn't going to be completely destroyed, or things like that. So we gotta kind of look at that line there. Deceitfulness or theft. These can be non-confrontational also. Broken into someone's car, house, a building, lying to obtain goods or favors, or even to avoid obligations. A lot of times we can look at this as conning others, um, and then just randomly stealing things that it doesn't matter. Like, why are you doing that? We can also see under that category shoplifting, and then theft without breaking and entering, or even forgery could fall into that category as well. When we talk about serious violations of rules, this is going to be more of those rules that are uh, associated with the age. So if we have a disregard of curfew, um, beginning before age 13, because again, we can see that as somewhat normal in our later teenage years. But before age 13, staying out past curfew, um, running away overnight at least twice, or being gone for an extended period of time. Now, this is one that we do also have to consider the possibility that they are trying to escape a abusive or generally undesirable living situation. So definitely kind of um, evaluate that, what's going on there. Um, Also with truancy, it's got to begin before age 13, because it's kind of considered a normative teenage behavior to skip school here and there. But with this one, it's going to be the age that we see that happening. So now just to talk about the specifiers, we've got this with limited prosocial emotions. So we're going to use this when we've got at least two of these criteria that are present pretty consistently in the past 12 months, or, um, or I guess, or, um, in multiple settings and relationships with others. Um, and the article that's going to be that I'm going to have posted is going to talk a lot about these specific um, symptoms. And most of the time, when we are assessing if these symptoms are present, we're probably going to need to gather some collateral information from more than one other source. Um, and that source is going to have to really know uh, the patient in question um, for quite a while, actually, to really be able to give us good information that can be utilized in assessing this. I'll let you read through those. If you have any questions about specifics of what these might look like, definitely let me know, but I think they're pretty self-explanatory. Now with level of severity, we've got mild, moderate, and severe. So of course mild is going to be we've barely made it to diagnostic criteria. And those symptoms of the criteria, or the symptoms that do meet criteria, are on the lower level of general severity. This is going to be stuff like lying, truancy, staying out past curfew without permission, or just general rule breaking. When we move up to moderate, then we're going to have more of the conduct disorder symptoms that are going to have a more significant effect, not just on the kid or teen, but also on other people. So this would be stuff like stealing without confrontation or vandalism, because those types of behaviors, they might not necessarily bring harm, so to speak, but it creates a situation that impacts quite a few folks. And then when we get to severe, and we're gonna meet this criteria either that we have a significant number of symptoms present, or we have symptoms that cause considerable harm to others. This is going to be for sexual acts, physical cruelty or aggression, use of a weapon, stealing while confronting, and sometimes breaking and entering, depending on the situation, is also going to fall into that situation or that category. Let's look at these differential diagnoses. Now this is, you've seen this before. I gave this to you in 541. And this is just how you can kind of differentiate between these three disorders more quickly. And something to just point out is that with oppositional defiant disorder, and I've kind of already said this, but the consequences or seriousness of the damage or injury that was done, they didn't realize that it was that serious. With intermittent explosive disorder, if we've got damage or injury occurring, one, it's impulsive, and two, the seriousness wasn't necessarily realized until after the fact. With oppositional defiant, we might actually have to explain why it was so serious. With intermittent explosive, they tend to kind of take a stance of, oh my God, I didn't mean to do that. I am so sorry. I don't know what I'm doing. That type of thing. And then of course, if we compare to conduct disorder, it's just going to be like, well, you shouldn't have made me mad. You deserved it. And then we've got, for each of these disorders, I've just given you a list of other common differential diagnoses that need to be ruled out. And that doesn't necessarily mean that they might not co-occur, but before we give these diagnoses, we need to make sure that the behaviors that we're attributing to one of them is not better explained by a diagnosis on this list. Etiology and risks. With oppositional defiant, we see a common history of unstable or frequent changes in childcare providers or just primary caregivers. We also see that harsh, inconsistent, or neglectful child rearing practices or parenting styles. Um, we've got that increased risk of suicide attempts. With prior to adolescence, we do see that oppositional defiant is more common in males, but then once we get into those teenage years, it's about equal. Um, I think the rest of this I've already kind of reviewed. For risk factors for development, like these are kind of self-explanatory. I will go over again the genetic and physiological risk factors because within that the article that's going to be posted, these are the specifics that can be associated with some of these disorders in this category. However, with oppositional defiant, we don't really see these as being as consistent. And we're also not sure if they're actually even associated, because when that study was done, the behavioral disorders were kind of grouped together. And conduct disorder was not, or oppositional defiant disorder rather, was not necessarily separated from conduct disorder, but conduct disorder was definitely the primary disorder being studied. So you'll understand when you read it. Now with conduct disorder, if we've got childhood onset, more often with males, more frequently co-occurring with ADHD, and then like I was saying, that tends to persist into adulthood. The adolescent, we see less aggressive behavior. Typically, we don't see the problems with social relationships as we might with the childhood onset. And then the ratio of male to females is pretty equal. The problematic is that a lot of kids with conduct disorder are going to receive less mental health care, and that's because a lot of parents and caregivers are just looking for a medication, and a lot of providers tend to give up on these kids. So it's actually kind of sad. Again, rare onset after age 16. There are risk factors. In addition to these listed here, just kind of talking a little bit more about that lower verbal IQ. What we think is kind of going on there, or is the cause of that association, is that we have a lower level of ability to interpret and then communicate. We're going to see more frequent misperception and misinterpretation of what someone else is doing or saying. And then that can kind of lead more into those more aggressive and hostile responses. For environmental, again, something I want to definitely make sure that you guys are aware of and recognize is that conduct disorder and oppositional defiant disorder, we do see a very significant association with relationships to primary caregivers or parents. We also see for conduct disorder learned behaviors, and then of course that history of abuse. And this is for genetic factors, looking at the physiological markers. And this kind of goes to the study that I was talking about. We see that uh, kids with conduct disorder have a lower resting heart rate. Interestingly, that is not seen with any other mental health disorder. So that is actually a very big uh, factor with conduct disorder. Um, and does also example that sometimes these types of disorders, or specifically conduct disorder, is not necessarily just um, learned behavior, although that's a big factor. And then finally, with intermittent explosive disorder, we do see a lot of depressive anxiety and substance use disorders that are associated. Um, the theory is that those develop as a consequence of the symptoms of intermittent explosive. Not really sure if this one is more uh, common in males or females. A lot of contradictions in those studies. It is interesting that we see highest rates in people between the ages of 35 and 40. So it is kind of a later adulthood um, disorder, but that could be because at that age and developmental stage of life, having these types of explosive outbursts are mm, not acceptable, essentially. And then finally, for environmental, with intermittent explosive, we do also see that history of physical and emotional abuse during the first 20 years of life. And so there is some decent association of difficulty with emotional regulation and things like that because of that experience. Genetically, we see a lot of serotonergic abnormalities leading to stronger amygdala responses. So remember that with our amygdala, it's an emotional fear response um, situation. Um, so that's definitely an interesting physiological characteristic here. And that is the end of this lecture. So if you have any questions, concerns, need some clarification, please don't hesitate to get in touch with me.